$725,000, so essentially $750,000. How do you even possibly arrive at that being an appropriate charge?
I don't know.
Okay.
I don't know the answer to that question.
It deviates into the realm of like it's illogical and you can't really figure out.
No, it is not. Yeah. It is not neither logical, not acceptable.
Welcome to Self-Funded with Spencer, sponsored by Pareto Health, ClaimDoc, and PlanSight. Whether we're discussing innovative new healthcare strategies, exposing hidden revenue streams or misaligned incentives, or even just cheering on the next generation of this industry, we promise you that you're going to learn something. So thank you for joining us for another great conversation about the future of healthcare. All right, guys. Well, let's kick off another episode. I'm excited today. I've got my friend, Dr. K, which I'll get you to actually say ultimately, because I know you go by Dr. K, but I'll let you pronounce it. But you are the founder of Hinkapin Health and ultimately the chief medical officer at NTTC.
NTTC.
There's an extra T, so a surgical center in Mesquite, Texas as well. So thank you, Dr. K, for coming on the show.
Thank you very much. And before I go any further, I want to say that I have, over a period of a couple of years that I have grown to know you and met you. You're a brilliant young man who has a very nice and a kind heart and a excellent interviewing qualities.
Well, thank you, sir. I appreciate you saying that. So Dr. K, I'll give you an opportunity. What does Dr. K stand for?
Dr. K stands for cool. No, not really.
Yeah. K, like cigarettes, cool?
It's my last name, Kikeri, Kikkeri.
Yeah.
And majority of my patients have trouble pronouncing that, and that's why I said Dr. K, and some of my patients said they call me Special K.
Special K, I like that too. Yeah, well, and Dr. K just sounds cool. You're right, it is kind of cool. But like, so if you don't mind, I'll put you on the spot here for a second. Give me the elevator pitch of what today's episode is going to be about, because I obviously know, but I want the audience to be aware of this is what today's episode is going to focus on, and then we'll build on it from there.
Fantastic. Today's episode relies on how to make affordable bundled surgery available to the business owners, TPAs, and self-insured employers.
Oh, well then this is right in my wheelhouse. There's obviously a reason you're here to talk about this. But the bundled surgery, I think it's a conversation I've had here recently. I don't think the episode's come out yet, but it is one that I wholeheartedly believe in this model, this financial model, to make these surgeries more predictable, less expensive, higher quality outcomes, et cetera. You know all the drill, and so you'll obviously get a chance to shine a light on that. But before we go there, I'd love to hear your story. I think you have just such an interesting story. You have a great personality, which I've grown to get to know the last couple months as well. But kind of tell us who you are. Where'd you grow up? You know, everything from education to early career. I'd love to hear all of it.
Fantastic. I was born in India.
Okay.
Part of my life I grew up in India, part of my life in United States. Therefore, I would like to say this with a lot of pride, that I have two mothers. One is a birth mother that's called India, another foster mother called America.
I love it.
And I love both of these countries.
Well, and those are the people that are just listening, because this is a video podcast. Some people just listen. You have a tie on with the American flag, which you're certainly, you live the things that you preach, and I appreciate you saying that.
So one of the things that, I'm veering off the subject, one of the things that we do not appreciate, we do not realize how grateful this country is.
Yeah.
And again, forgive me for veering off. When I went to Haiti during the earthquake, majority of the people who took their own private plane, paid their own money to hire people, paid their own money to buy supplies, they're Americans. We did about 70 to 80% of help in a situation like that.
Yeah.
When I go to Europe and when I go to any other country, when I come back, I realize how beautiful this country is.
Well, and again, you practice what you preach. We had lunch before this podcast, and I saw you go up to a gentleman that you found out he was in the armed services, and you purchased his lunch for him as well. And I know you have a familial connection, right, with the U.S. Armed Services as
yes,
well,
sir.
Right? Yeah.
Yes, sir. And I lost my uncle in World War II.
Okay.
And of course, it was before I was born. And my brother worked in Navy, and my cousin is a full bird colonel. Was a full bird colonel in the U.S. Army.
Excellent. Awesome.
So, and we are very, very proud of our men and women in uniform.
I love that, man. And I appreciate you saying that. And so let's go back. You were mentioning, we veered off subject just for a second, but I definitely appreciate your love for this country, and I share your love for this country. So you came to the States, I think you said when, I don't know if you mentioned it on air, but when you were 25, correct?
Yes.
Okay. You and your wife at the time? Or?
Oh, since you asked,
Yes.
I was I was just out of medical school.
Okay.
Just started my practice in a small town called Bangalore. Not a small town. It's a big town called Bangalore in South India.
Okay.
And I was taking care of an elderly gentleman who, without my knowledge, had arranged for her granddaughter to come and visit me.
Okay.
So, and he was in a hospital, and I was his attending. So I met my wife in her grandfather's hospital room.
Did sparks fly and you hit it off immediately, or?
And even now, I tease her saying that we have been beautifully married to that beautiful girl. I have been married to that beautiful girl for the past 33 years.
Fantastic.
And even now I say I married her for the green card.
You married her. She probably doesn't like that joke.
No, she didn't.
Well, how did you guys decide ultimately on moving to the U.S.? Was it a mutual decision? Was it something you really always longed to do? Tell me about that.
One of the things is that I always wanted to pursue my higher education, and I wanted to come to America. So, and it so happened that she's an American citizen, and she was in dental school at Columbia University in New York.
Okay.
So I came with her.
You came with her. I love it, man. So early days in the U.S. You're an anesthesiologist by trade,
I am.
Correct? Okay. So at that time coming to the States, were you practicing as an anesthesiologist, or were you still in residency, or?
No, when I came to this country, I had just finished my medical school.
Okay.
I had not done any residency or postgraduate training. So I started my surgical internship in Stony Brook University, SUNY.
Oh, yes.
SUNY New York in Stony Brook. And then subsequently did my anesthesia training in Beth Israel, New York, in Manhattan.
Okay.
And got more training in Albany Medical Center, Albany, New York. So I practice now in Dallas, Texas.
Okay. Well, so ultimately, New York was your first, entrance into the U.S. and Texas and New York are quite a bit different. Did you choose to come to Texas? Did you, or was it was a job that brought you down here?
So please understand, coming from South India, Bangalore,
Yeah.
the New York winters were really bad.
Oh, yeah.
And especially when we lived in upstate New York. When I was on call, I could not even get out of my driveway. The firefighters had to come and extract me out of my house so that I can go and take care of a patient in emergency.
Sure.
So then I realized that I'm really not built for that cold weather.
Yeah.
So we were looking, and both me and my wife, we had two choices, either Florida or Texas. My wife and I both fell in love with Texas.
That's awesome.
So we just made a decision to move to Texas. So
did you move to Dallas originally?
Dallas.
Okay, very cool. And so at that time, your wife is, you said that she's a dentist, correct?
Yes.
Or I guess was a dentist, no longer practicing. But so were you guys both at the point of practicing full time?
Yes, absolutely.
Okay,
at that time, we had our two boys.
You had two boys, okay.
Two boys, little ones, and we moved to Texas. So
Pareto Health is the manager of the largest employee benefits group captive in the United States. And it's also now the main sponsor of the Self-Funded with Spencer podcast. I chose to partner with Pareto Health for three main reasons. Number one, their dedication to improving the world of health benefits. Number two, their mission to reduce volatility and to make self-funding simple for mid-sized employers. And number three, the strength and scale of their program. With over 2,300 member groups and more than $1 billion of stop-loss premium under management, Pareto Health is the most robust solution of its kind in the country, period. Stay tuned for more information because I'm sure I'll be featuring him on an episode of the podcast very soon. Visit Pareto Health at paretohealth.com or follow them on LinkedIn to stay up to date on the latest news and developments. I got to ask, because this is always fascinating to me, because I've interviewed a number of people from across the world who have found themselves in the U.S. Intentionally, right, but ultimately found themselves interacting with the U.S. healthcare system and maybe interacting and finding out they had this, pivotal moment where, oh my God, is it really like this? And that started them on the path to solve certain problems within the U.S. healthcare system. So tell me, early days practicing, especially dealing with the insurance model, what were your early impressions?
That is actually, that component was more difficult than learning medicine.
Okay.
That was more difficult than really what anybody would make out for. Even today, there's not enough education in medical school to learn about how to deal with insurance companies. Mm-hmm. Mm-hmm. So I went through the same thing, and it was very difficult, very challenging. Subsequently, when I was practicing in Dallas, Texas, a door opened up where I looked into what other options we have.
Yeah. And when did you discover that there was something else out there?
During Affordable Care Act.
Okay.
When I practiced anesthesia and pain management, and during one of the days when we decided to build our own surgery center, mm-hmm. both me and my wife. So because pain management needs some surgical time for either injections or spinal cord stimulator or what have you, pain pump or what have you. So when we built our surgery center, in one of those operating rooms, the general surgeon was working, and I was in my pain clinic, which is in the same building.
Okay.
So I got called from a general surgeon saying that, hey, Nagaraj, can you come to the operating room number 3? So, I excused myself from the patient room, and I walked over to patient into the OR3. And he pointed out to that TV screen, he was doing what's called a diagnostic laparoscopy.
Okay.
Where you go and do almost like a recon as to what's happening.
Is that the small camera that would go in?
Yes,
okay.
Small camera through a small keyhole incision with, that goes in there and just looks around.
Okay.
Couple of keyholes in the belly with they insufflate that with some gas.
Okay, so it expands. I guess.
Expands. Yes. It becomes so the organs don't stick. They open up and you can see.
I see. Okay.
Okay. And when he was showing me, he pointed to the patient's liver, and then he just said, "Can you see what's on the screen?" And on the screen there was like diamond-studded spots on the liver.
Okay.
And that was an ominous thing.
Okay.
Very sad. And that was the metastatic cancer.
Oh, okay.
That is not the point. The point was that he said, Nagaraj, go look what is on the other side of the ether screen. Mm-hmm. And when I looked, that was one of our patients who used to come to us to get a routine colonoscopy.
Okay.
She used to come and get a routine colonoscopy, but we had not seen her in some time. And come to find out that she could not afford to get a screening colonoscopy mm-hmm. because her deductible was about $6,000 to $8,000.
Yep.
How many of us are walking around with $6,000 to $8,000 in our pocket?
Right.
Not many.
Not as a percentage, not many at all.
No, not
Absolutely
at all.
not. Yeah.
So she stopped coming. Her precancerous condition became cancerous, mm-hmm. and it started spreading, metastasized everywhere. Yeah. And when it went to liver and it spread like a wildfire.
Mm-hmm. And so you were able to track back, right, or at least presuppose that if she had continued those routine colonoscopies.
Because she was our patient.
Right.
She used to get routine colonoscopy at our surgery center.
Right.
She stopped coming. And because we knew the family, because we knew her familiarity with her, because she was coming very regularly. To break that news was to the family was really hard.
Right.
And the kid said, I wish I knew mom had this. We would have pitched in money to get her done.
Right.
And that was our nodal patient, which this was like the kick in the rib.
Well, and probably the genesis of this idea, right, where
Yes.
the financial constraint is often the thing that's causing the behavior,
Yes.
which ultimately is preventing somebody from seeking out care that they probably do need, even if it's preventative, even if it's ultimately more of a discovery, right, than it is a necessary care right at the moment because I'm in pain. You go, okay, well, how often is this happening? So then, did that lead you down this path to discovering there's another model for payment that's more cost effective?
This was like a paradigm shift for us.
Yeah.
This was like a soul-searching moment for us. So one of the most beautiful thing I have is that I have wonderful people working with me.
Okay.
So my surgery center director and a Hinkapin Health surgical director, Adam Hornback, myself, and a couple of our very dedicated nurses and staff members, we put our heads together saying that, listen, colonoscopy is not $8,000. Mm-hmm. It should not be $8,000. Mm-hmm. So let's come up with the concept of how do we make this affordable in this day and age in United States.
Right.
So that was the genesis of bundled surgery program, mm-hmm.
where
patients come, pay one price, and I'm going to borrow that bottle.
Oh yeah, could you get having the Topo Chico bottle? We're gonna.
Yeah, so one bundle price. The concept was, it's like.
Thanks, Nathan.
Thank you. It's like when you buy a Topo Chico, you go to the grocery store and you pay for it.
Right.
And then say, oh, no problem, Dr. K. You can buy the Topo Chico. We'll send you the bill for the bottle later.
Yeah, we'll let you know how much it is, right?
Yeah, and we'll let you know. And then we will also find out how much we're going to charge you for the cap. I'm sorry, we forgot to mention about the carbonation. We'll charge you extra for that.
Right.
And that concept is what's going on in the healthcare these days.
Right.
So we had to get rid of this and come up with a way to make it simple, affordable, high quality, and we owe it to that beautiful lady who gave, unfortunately, it was a cause to do something great.
Well, and you describing that, and I appreciate you that analogy and obviously telling her story. But Nathaniel, he came up with a brilliant idea not too long ago that we shot. The whole idea of MAC versus PC, self-funded versus fully insured. You'll see where I'm going here in a second. But this particular script Nathaniel came up with is this notion of networks, right? And depending on who's paying, if you go here, it's double the cost, but if he's over here, it's only a quarter of the cost. But ultimately, the delivery of the service or the procedure has a cost to it, irrespective of who's paying for it. But depending on who's paying for it in the insurance model will dictate how much is billed, how much is discounted, and how much is allowed. And it's a nonsensical model, and it's just what you eloquently pointed out with the Topo Chico analogy. And so I look at it and look at the inverse of that. So let's say that's a terrible way to decide how much something costs. The other side is, what does it actually cost? And how much can I deliver for it with my own profit built in, right? Because it was still capitalism. We still want you to make money. But why can't I just come up with a cost to do this thing and charge people whatever that amount is, right? And it almost feels like so obvious because it is, but that's just not the way we've done it for so long. So then when early days of trying to set this up and explore, the colonoscopy example that you used, how did you come up with a price originally? Walk me through how you came up with that
Absolutely.
number. Yeah.
One of the few things, I'm very glad that you're asking a really, really very relevant and thought-provoking questions. In the early days, when we came up with that, we found out what each person involved in this cost charge us. Mm-hmm. Surgeon's fee, anesthesia fee, pathologist fee. How much does it cost for the supplies? Mm-hmm. What does it cost to pay the nurses and the support staff their salary? Mm-hmm. And what is our profit that we can live with without making it sound like a highway robbery?
Right.
Okay. So when we came up with that, we honestly came up with a number that is palatable for everyone. Okay, so we made that, we put our bundle together, what's called a bundle surgery.
Right.
And I'm going to veer off a subject a little here.
Okay.
Majority of the time, when you go and have a surgery or any medical procedure done, you will either, you will not know how much it's going to cost. You will keep getting the bills from different entities that you did not even know they were part of your surgery.
Part of the equation, yeah.
Yeah, you will get billed from a surgical first assist. You did not know that there is something called first assist. So you will get a bill from an anesthesiologist or a surgeon saying that, oh, he's not in network, he's out of network. Talk about confusing.
Yeah,
so we needed to eliminate all those things. So you pay one price so that the bundler, like myself, we will take care of giving to the surgeons, pathologist, anesthesiologist, to the facility. So there is no confusion, there is no balance billing, there's no surprise.
No surprise and no balance billing, which is obviously part of recent legislation as well, which is a good thing. It's
fantastic.
It's a step in the right direction, right? But at the end of the day, if I'm gonna throw out a number and just use whatever that number is. Let's say it's $600 for a colonoscopy. I don't know. Do you have the number? Do you remember the number that you use, or do you promote it externally?
We do. I do not remember on the top of my head, but it is on our website. I think it is $1,600.
$1,600. Okay, so $1,600. You come up with this number. You can almost lead with it, right? Ultimately, you can attract business. Dr. Keith Smith was here a few weeks ago. Kind of a similar notion. I know you know him well. Ultimately, it's not a novel concept. That if I want to attract business in the United States of America, one of the ways that I can attract said business is by letting people know what it costs to do that. And it seems like such an obvious concept. And at the end of the day, all parties, so that bundle, I'd love for you to describe in your own words, when we say bundle, what do we actually mean by a bundle? But at the end of the day, it's the all-in price for the cost of goods sold and the cost of services plus your margin, and we move on and we do it again. So when we say that bundle, though, like that term bundle, describe for me exactly what's inside of that bundle.
Fantastic. By the way, I want to say Keith Smith is a wonderful human being with a very golden heart.
Yep, I would agree with you, man.
And coming back to your question, bundle. A component of surgery usually includes, these are what is included in a surgery. Number one, there is a pre-operative visit to a surgeon.
Okay.
The surgeon determines, okay, this patient needs a surgery. Okay? And then subsequently, the surgeon books the surgery at either a hospital or an ambulatory surgery center. Okay. And from the time the surgery is scheduled, patient will receive a call from the staff from the surgery center, and probably from the anesthesia as well.
Okay.
And they determine that this patient is suitable for this facility, a surgery center. And once when they're determined, they will come in and they will be in the pre-operative area where they get their IV put in, and then if, for example, if they're having a hip replacement or a knee replacement surgery, the anesthesiologist will do the necessary pain blocks ahead of time, and then the patient will receive the medications. And once when they receive what's called a pre-medication, and the patient, after meeting the surgeon, after going through the safety checks, after meeting the nurses, the patient will be wheeled into the operating room.
Okay.
And in the operating room, after they do what's called a safety check, patient will have the surgery under anesthesia, and then once when the surgery is done, the patient is wheeled back into the recovery room where they recuperate and they leave. Once when they meet the criteria. Now, the reason why I mentioned this, what I just mentioned it's very routine. It's nothing new. There are so many people involved in this, starting from nursing team, anesthesia team, surgeon's assistant, and then operating room technologist, and then the anesthesia, as I mentioned, and then there is people who supply the hardware.
Oh, yeah.
Okay, and then once when they come into the recovery room, the anesthesiologist will check them again and then discharge the patient home. So therefore, the bundling involves all of these components.
Yeah.
Some of our bundle even involve the pre-surgical consultation fee and the post-surgical consultation fee as well.
Well, and so I see why it's so difficult, right? Because there's so many people involved, there's so many steps involved. However, it's not like it can be done. It has been done. Dr. Keith Smith has proved it. You've proved it. A lot of other folks have proved that it can be done. Why is it so difficult for, in the fee-for-service, the insurance style model, to be able to tell someone a price before they get the surgery itself? Why is that so hard for them to do?
When your brain is programmed that the only way it can be done is through submitting your insurance.
Yep.
And when your brain has been for years and years and years that accepting cash is criminal, it's very hard to break that.
Yeah.
So therefore, people don't understand that this can be done and it is available and it is legal. We're not doing anything illegal.
Of course not. Yeah.
So we're making it available, simple, affordable, high quality. So this is one of my main reasons why I'm with you today, is to educate them that it is available.
There's awareness, yeah.
Please use it. Decrease your surgical spend.
PlanSight is a complete game changer in the world of insurance brokering. As a broker, you know how time-consuming and error-prone the traditional RFP process can be. But what if I told you there's a better way? PlanSight is the only end-to-end RFP solution on the market made specifically for benefits agencies. It's like having a superpower that gets you an average of 8 to 10 hours back per employer renewal per year. And the best part? PlanSight supports all carriers, all funding types, and all group sizes for over 20 different benefits. If you're ready to make your RFP process faster, more efficient, and more profitable, it's time to call PlanSight. Visit plansight.com now to book a free demo and discover the future of insurance renewals.
But one thing I do want to ask you, because you have your surgical center, what is it about just even that location as a facility, as an alternative, this ambulatory surgical center versus a hospital setting, that also helps drive down costs? So give me some of the economics behind why that's the case.
Sure. It's a very good question. Ambulatory surgery center in the state of Texas have been there for a very long time. It's an ambulatory surgery center where you can do majority of the surgeries that can be in a patient that is well suited, who is medically stable. This is not the place for emergency, like life-saving surgeries and certain major surgeries. But nowadays, a lot of these surgeries are done in ambulatory surgery center. Number one, it is a smaller entity.
Okay.
And
less overhead, right?
Yeah, less overhead.
Yeah.
And number two, it is also, many a times, it is privately owned.
Okay.
Okay, there is no big brother trying to tell you what you need to be doing. It is also regulated by AAAHC ambulatory. That's an accreditation where it is closely, the quality is controlled.
Sure.
Okay, so there is no, it is not like, okay, you open a surgery center in the back of your house.
Sure.
So it is well controlled. Now, when you're in a surgery center, it is not as huge as a hospital. So you're not exposed to the cross-contamination and in hospital-related infection.
Yes, yeah.
A super bug that is resistant to almost all the antibiotics. And of course, there is the quality of care is under a lot more control. The outcomes and the patient's acceptance over a period of time it's been shown over and over and over again that ambulatory surgery center in the right patient is an excellent choice.
Absolutely. It just sort of continues to dispel this misconception that cost equals quality in healthcare. Oftentimes, if not almost in all cases, quality and cost actually have an inverse relationship. And for a lot of the reasons you just described, there's fewer Sounds like there's fewer variables in a surgery center. You mentioned obviously the cross-contamination of potential. You've got somebody there that's really, really sick for one reason, completely unrelated to surgery, but they happen to be there and it might be an airborne illness, and now you've got a hospital-acquired infection, right, that might cause complications or, maybe even be detrimental to somebody's life as a result of that. But then you pluck that particular subset of procedures out, you put it in a surgery center, fewer variables, the patients are obviously coming in a more elective manner, they're more stable, the screening process, et cetera. And so I can see why. It just makes sense logically to me why infection rates may be lower. Is that the case? Just broadly speaking, infection rates end up being lower in a surgery center on average?
Not just infection rate.
Okay, what else?
I'm going to dial back a little bit in your conversation.
Yeah.
So you mentioned at the beginning of this conversation, in your own earlier podcast, which I very regularly watch and enjoy.
Thank you.
And in one of those podcasts, one of your guests said that there is a misconception that higher price means higher quality.
Mm-hmm, mm-hmm, mm-hmm.
Okay? So let's sit back here and go back to my Topo Chico. The Topo Chico, I can buy it for $1.25 in my local store, or I pay $35 in a very fancy schmancy bar.
Uh-huh. Yep.
Okay? But it's the same Topo Chico, right?
Yes, yep.
Nothing different. It's made in the same factory. It's transported probably in the same truck.
Yeah, probably.
So take the same analogy. Surgery, just because it's charged a higher rate doesn't mean you're getting a higher quality. Mm-hmm. There are some components of the quality that is very relevant. Mm-hmm. What are those components? In a broader sense, the one indicator that spells the quality of a surgery center or a hospital is the infection rate. The infection rate is the one that happens during surgery. That tells a lot of story about that particular center. It tells whether instruments are being sterilized properly. Are we keeping a good log of the sterilization? Are the instruments being washed properly? Are they being handled appropriately?
Right.
Are the surgical techniques where the surgeons and the techs use, is it up to par? Is it a good standard? Mm-hmm. Mm-hmm. And how do they preoperatively care for the patient? How do they select the patient? All these things play into, and these things are important, not the price. In other words, like higher the price doesn't mean that higher the quality.
Yeah, you had a recent example, I think, with some folks close to you that got a similar procedure but had dramatically different price points ultimately for that procedure. So I don't know if you want to share that story, but it's pretty astonishing when you went to the numbers with me. Yes. I think you know what I'm talking about.
Yeah, I know.
So tell me what happened, if you don't mind, and that we can just kind of paint an anecdotal picture of the extremes of the spectrum.
Yes.
Here, right? Yeah.
Your point. This is something that happened in my family, I'll say that.
Yeah.
So one member of my family, a young lady that I'm very close to, and had a total knee replacement surgery done at our surgery center.
Okay.
And came in the morning, had the knee replacement done, and that afternoon around 2 or 3 p.m., she walked with a walker to the car, and we took her home.
Okay.
And from our driveway, she walked to her bedroom.
Yeah.
And that's something. And her bill at that time, it was $18,000 or $20,000 total. Total.
Yep.
Surgeon fee, anesthesia fee, hardware fee, and facility fee.
Which, on the surface, I don't have a ton of experience here, but $18,000 to $20,000 seems like that seems like a fair price for a total knee replacement.
Contradistinction. I'll give you another family member of mine.
Yeah.
Who, within a matter of 2 months, I'm not talking about years, 2 months, had double knee replaced.
Okay, so two. All right,
Two
so
knees.
we're dealing with two. Okay.
Yeah, buy one, get one free. No, she needed two knee replaced.
Yeah.
Granted that this was slightly older lady, and by no means like super high risk. No. She was in the hospital for a day, and then subsequently went home. Mm-hmm. And of course, it was a traditional insurance, and the charged amount. When
well, let's pause. Like, what do you think? I'm going to say at the audience, if they're listening right now. So a little bit. Let's summarize. A little bit more complex use case: an older person, double knee, and an overnight stay. Right.
Yes.
So like we could presume the fair price may be 3 to 4 times. I could say that maybe that's a fair amount. So then, in your head, if you're thinking, what do I think billed charges are in this situation? So, what do you? So you'll get a chance to reveal. I mean, it's almost like what would be fair. I don't know. It's somewhere more than twice as much, of course, because it was 2 in a different setting and an overnight stay. But still, and I'll give you a chance to reveal what the actual bill charge is.
No problem. So let's say double the price. Mm-hmm. Okay, overnight stay, triple it.
Okay.
And then elderly person needing more care, more specialty, more specialists involved, quadruple it.
Right.
That comes to 20,000. Let's call it 20,000.
Okay.
Okay. And that comes to about $80,000.
80, yeah. So we quadrupled the 20, we get to 80. Easy math. Yep.
Okay, you know what? I feel generous. Why don't you have 20 more?
Okay, so 100 grand.
$100,000. I feel very generous today, so $100,000. But now I'm going to reveal what was the charged amount.
Yeah.
The charged amount for that particular patient, a family member of mine, was $725,000.
Right. $725,000. So essentially $750,000 were billed charges.
Billed charges.
Which obviously we've already differentiated, but that's what's billed.
Billed.
Ultimately. And then obviously there's negotiations and repricing, et cetera. So what was the actual allowed charges that were ultimately paid on that case?
$150,000.
$150,000. Okay. So $150,000. Even in every possible way, we tried to be generous to get to the number. 100 was what the worst case scenario we thought. And so it was 150 grand that was paid for that situation, right?
I apologize. I misspoke.
Okay.
It was $225,000.
$225,000. So even worse, right?
Yeah, $225,000.
And so when you look at that, right, and we obviously played it up a little bit, but when you look at that, I mean, how do you even possibly arrive at that being an appropriate charge? I mean, I can't, because we're literally talking about, even if it was 2 knees, so 40 grand, we're literally talking about a 6x outcome, a 12 when you think of just 1 knee versus 2. I mean, that's an extreme multiple of what was allowed to ultimately be paid for that situation. So how do we get in such an egregious difference between the two?
I don't know.
Okay.
I don't know the answer to that question.
It deviates into the realm of like it's illogical and you can't really figure out.
No, it is not.
Yeah.
It is not neither logical, not acceptable.
Yeah.
Because imagine if I was not in the medical field, for any person, if they were to receive that amount, that piece of paper, I'm thinking, oh my God, I need to sell my kidney and the liver on Craigslist. Mm-hmm. I will still not get that much money.
Yeah. Yeah, I mean, it's more than most people's houses cost.
My
right?
God,
yeah,
yes.
Yeah, it's such an insane amount of money for something that's been done for, what, decades? How long have we been doing knee replacements in this country?
I can very confidently say that before you and I was born.
Okay. So routine, long-standing, proven procedure. Maybe the hardware's changed ultimately, but we can do it, and we've done it probably hundreds of thousands, if not millions of times in this country. And yet,
you can say millions of times.
Millions of times, right? So then ultimately, we have such a disparity between the two. And so all it really does is, what we're trying to shine a light on is a more efficient, more logical, more cost-effective way to do these things, and that is in this bundled surgical model. However, I think the place that we go next, let's segue, is that you're still one man within one surgical center and in one location, and ultimately you can only touch so many lives or so many employers as a result of that. So enter the fray, right, this notion of Hinkapin, which is the way that you're sort of exponentially able to expand that. So why don't we define first, what is the difference between Hinkapin and your surgery center, and why did you stand that business up?
Fantastic. Actually, while I was in my pain clinic,
Okay.
one of my patients who saw the advertisement that was there on the lobby, and he said, "Hey, Dr. Kikeri, our factory has a location in Austin. How can you help us in Austin? I like the way what you're doing for our company here. Our HR director, our CFO loves what you're doing in Dallas Metroplex. But how can you help us the same way in Austin?" And for that, surgery center, the NTTC surgery center cannot do that, because NTTC surgery center is not meant to refer patients to another surgery center.
Okay.
Out of necessity, Hinkapin Health was born. Hinkapin Health is a care concierge company where we curate cases in different areas, in different centers.
Okay.
Again, the emphasis is that we curate only if the quality metrics are met to our standards.
Still using a bundled surgical
Still
arrangement.
bundle price.
Okay.
And please understand, these bundles are not astronomically high, but there is a regional price variation.
Of course there is.
And we have to be respectful of that and aware of that.
100%, right? Living in California is more expensive on average than living in Texas, just obviously. Okay, so that makes sense.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
But then did you expand? So not only are we able to expand sort of the geographic footprint of which we can deliver these services, and you help coordinate and kind of set up the connections, right, ultimately for these employers. What did you expand perhaps the types of procedures and surgeries you were doing as well? Does it allow us to sort of open it up to a lot more things?
One of the things is that it's a natural progression.
Yeah.
We started with a simple colonoscopy and then branched out into different specialties.
Okay.
So the necessity is the mother of invention. So in our situation, the surgical dollar spent dictates what our TPAs, our self-funded clients are asking us for. They're, in other words, right now, the musculoskeletal, spine surgery, including spine surgery, orthopedic, and then the next one is cardiovascular surgery.
Okay.
And of course, there is other bread and butter surgeries like general surgery, ENT, and
so all these type of surgeries can be
all
done
this,
in bundles.
all these type of surgeries.
Yeah. Okay.
So we started prioritizing what the requirements are. So because we have been doing it for quite some time, so we offer to some trucking companies, their needs are different than a fabric company. So we tailor it to their needs.
That makes sense. And so, like, if I'm, thinking along the lines of a consultant listening to this, or maybe even employers that are listening to this, the idea is that I can deploy them through a self-funded employer. I can set this up as a part of their self-funded plan, right? An enhancement, perhaps, to the self-funded plan to save money on these types of procedures. So how do you go about sort of working with those brokers to find the right employers, and what kind of employers are you ultimately looking for there?
One of the biggest things is that how do you make aware that this is available to you?
Sure.
Okay.
You go on podcasts and talk about it. That's one way to do it.
Thank you.
Yeah.
Going on podcast and being a member of different community, and also being, in this day and age, networking is supremely important. And I really, really salute the healthcare heroes like yourself, because you are making this so much more accessible, available
That's
to
it,
other
yeah.
people.
Thank you. Yeah.
And please don't ever take that lightly, because when you do this, you're also saving so much money for the employers who are struggling.
Yeah, I mean, I certainly hope so, right? My goal is hopefully to influence the sort of the thought process to a degree towards these type of things. And then if they do get deployed because they are the right fit, then ultimately it saves a plan money, and that trickles. I mean, it's literally that entire trickle down process to the individual families, and that's what I want. Families to save money on their health care.
A really big shout out to people like you, brokers, and the benefit advisors,
Yes,
and
yeah.
TPAs.
Yeah.
Folks, you are touching lives in a manner that is imperceptible. People, look at yourself as heroes.
Right.
It's not just the surgeon who cuts the belly. You are also a hero.
Yeah.
So, and when you do that, when you made a point, you drove a point home, is that when you don't have to mortgage your home, when you don't have to take money from your kids' college fund, those things do matter.
Absolutely do matter. Absolutely, man. I mean, and there's no reason we can't make healthcare more affordable. We can still keep all the innovation that is, culminated from this system. But the way that we pay for things is the problem, right? And so when I look at something like Hinkapin, it says, obviously, yes, we should be doing more things like this. And so the deploying, right, it's got to be a self-funded employer to do this, correct? Ultimately, yes. Okay, so we got to be a self-funded employer. Does network constraints sometimes do you run up against? Some of the BUCAs won't allow it even on a self-funded plan, right? So we're probably going to have to deal with independent TPAs and networks that have a little bit more flexibility, or reference-based pricing plans, I assume, as well. And so I'm just thinking about the expansion of this idea. Like, how many states are you coordinating within today with Hinkapin?
We are the Hinkapin. Before I delve into that,
Yeah, please, yeah.
One of the things about the Hinkapin Health is the way we function with the medical knowledge in the background.
Okay.
Hinkapin Health is not a medical company, but with the knowledge in the background, using a really caring kind concierge service.
Okay.
To make the transition to the patients very smooth,
Okay.
so that it can be administered in Dallas and multiple different cities throughout Texas.
Okay.
And the transition becomes very smooth for a simple reason. No matter where the patient is, the process is the same.
Yeah.
Kind, caring, gentle approach. And patient selection, proper safety and quality metrics. When these things are maintained, all these things, to answer your question, we are spreading to other cities throughout southern United States.
Okay, excellent. And then, so what will help with that growth? Ultimately, obviously, finding the right employers that believe in this model, using consultants to expand it. Are there any kind of headwinds or constraints that you're having to deal with now?
Oh, absolutely.
Okay, so talk
absolutely.
What are some of those headwinds? Other than maybe political headwinds, right? I'm sure that's some of it.
I think I'm going to differ. I'm not going to speak about the political headwind today, but headwinds today. But one of the biggest difficulties from a medical perspective is that some of the surgeons and providers, they don't know that they can take cash. Their hospital, their office staff does not know how to accept this. And this is from like HR managers' perspective, from, oh my God, if I utilize this, will I lose my job? It's a very, very practical and relevant things. And afraid to make changes, and afraid to take a necessary risk. A well-calculated risk is another headwind. And another thing that I see very commonly is that, because you're offering it is so inexpensively, like, is the quality? They doubt
Yeah,
big doubt.
I understand that. Yeah.
One of them even asked me if I'm doing the surgery in the back of my double wide.
Yeah. Yeah.
I did not, that didn't even occur to me that, oh my God. And one of the beauty of these things is that some of the nurses who are involved in their care navigation in their particular TPA, we invite them, come and see us.
Yeah.
See us in action. And in fact,
I was going to say, I had a chance to spend half a day with you and observe procedures, and it's really eye-opening, because I'm just witnessing the whole process. Every once in a while you would pop over and say, hey, this is what's going on here or going on here, just to be an observer inside the room and see obviously the quality standard that you keep. But patients are even smiling sometimes on the way in, and you guys are joking around, playing some music. It just looked like an environment that was fun, but it was still business, right? You're still there to do certain things to help these people with their pain. And so I appreciate you open up the doors. That's actually the first time I've ever had a chance to do that, which is really neat. But I think ultimately what you wanted me to see too is like, this is a high standard at which you conduct care. Because there is still that notion, unfortunately, that if it is a lower cost, that there must be corners being cut somewhere, or something to that effect, right? And that absolutely is not the case here.
No, not at all. Not at all. Thank you for pointing that out.
Yeah. Is that me or you? No, sorry.
Oh, I'm so sorry.
No, it's okay. But what I want to get at as we sort of kind of move towards the end, Dr. K, is what would be a home run for you? Oh, are you on call? I know you might actually need to take this. Do you need to take?
No. I will. Actually, somebody else is covering me.
Okay.
I apologize.
That's okay. This is what happens when you interview doctors that are in demand. Sometimes they might actually be called during the podcast. It's all good. Cool. Okay, so, and we'll just keep that in. There's no reason to edit that out. What I was going to ask you, though, is I was going, ultimately, what is like kind of the moonshot for you? Or what's the home run here, to use an analogy? For you with Hinkapin, what's the big goal you're trying to accomplish? I understand the purpose on the ground floor, but what is the big goal where you could look back at a certain time in the future and go, I did what I set out to accomplish?
You brought up a question that is very guttural, very, very deep to my heart. I decided to be a doctor when I was in 6th grade.
Oh, really?
6th grade.
Okay.
My dad asked me, he said, hey, what do you want to be when you grow up? Don't ask me why. My dad asked me, and I was about to enter and take a shower. That is the question I had in my mind. And I told him, I have two things in my head, Dad. Noble soul. He would encourage me right from the beginning. And I said, I have 2 things in my mind. 1, I want to be a doctor. Mm-hmm. 2, I want to be a pilot. I don't know which way to go. Mm-hmm. And then my father paused for a minute and he said, listen, if you become a doctor, you can also become a pilot. But the other way is more difficult. Mm-hmm. Mm-hmm. Don't ask me why. That stuck with me.
Yeah, that's interesting.
That stuck with me.
Yeah.
So now I became a doctor. And because I had something innate that I wanted to do this for my livelihood, for my career, and for my calling. Mm-hmm. So now, take that concept of being able to help lots of people, not just one patient or a few patients, a wide variety of people. Mm-hmm. In this day and age when they are struggling to make ends meet. Mm-hmm. That is my intention. Okay. If I can accomplish that, then I have accomplished what I set out to be.
Awesome. I love that. So last question for you, Dr. K. We've talked probably an hour or so, and I really appreciate you lending your voice to the show. I love the mission, right? I love the why. I mean, I'm always compelled by people's why, and it connects me to them, so now I understand what your purpose is. But folks that have listened through for the full conversation, we covered a lot here in this hour. What would you kind of want to leave them with? A point or something to think about as they go about the rest of their day?
One of the things, please think, there is 3 systems that's emerging in, the third system that's emerging in the United States for healthcare. Mm-hmm. One is a private insurance, mm-hmm. the other one is governmental insurance, and the third option, the bundled, affordable, high-quality healthcare, mm-hmm. is a viable option.
Absolutely.
Use it. Use it so that you can save some money for everyone and provide a great quality and help people.
I love it. Awesome. Well, thank you so much again, man. Again, thank you for opening your doors to your surgery center. Thank you for coming on the podcast. It looks like we might have an Italian dinner perhaps coming up in the future with our wives as well. So thank you for your generosity, and I can't wait for this episode to come out.
Thank you very much. I totally enjoyed your brilliant interview.